Hello to all. Thank you for the organization committee for this nice event. And we will talk about ah, now we will talk about tips for laser treatment. I have no financial disclosure. As you all know, the laser treatment is the current gold standard for ROP treatment. It has both favorable outcomes for structural favorable outcomes and functional outcomes. We can use laser treatment as primary treatment for ROP cases, or we can use it for recurrences, especially after the anti-VEGF treatments, or we can use laser treatment as a combined therapy with anti-VEGFs. Our objectives for treatment are to downgrade the abnormal vascularization with minimal complication, to prevent retinal detachment, and to have anatomical success and functional success. Dr. Kadayıfçılar talked about the current indications of treatment. We can choose laser treatment, especially for the zone 2 cases, more peripheral cases. And timing is so important for treatment. If we treat the babies at type 1 pre-threshold stage, the unfavorable results decrease significantly. For type 1 ROP cases, we must treat within 72 hours. For aggressive ROP cases, we should treat within 1 or 2 days as soon as possible. We have two options for laser: diode laser with 810 nanometers wavelength or green laser. There are some differences between these two lasers. Hemoglobin cannot absorb diode laser. Diode laser is not absorbed by hemoglobin, so it is more usable in the presence of retinal or vitreous hemorrhages and more usable in the presence of tunica vasculosa lentis. And the cataract risk is less, especially for the babies with tunica vasculosa lentis. It's different for melanin. Melanin absorbs diode laser, so diode laser causes more deeper burns, more pain, and visibility of spots are less with diode laser. There are many studies comparing these two lasers, but there is no important difference between them. We should have a checklist before the laser treatment. Of course, we need a laser console and protective goggles, protective glasses for us. Condensing lens, not only 20 diopters, but we also need 28 or 30 diopters lens. Sterile linen clothing is important to warm the baby. Sterile eye speculum, we can use infant type Alfonso speculum. Scleral depressor, flin or wire rectus, or we can use just sterile cotton tipped buds. We need dilating drops, anesthetic drops, and irrigating drops. We can use Ringer's lactate solution or balanced salt solution to humidify the cornea. Preoperatively, the informed consent is so important for medical legal issues, and we should check the preoperatively pupil dilatation because it affects the success rate and complication rate. We have anesthesia options. We can use general anesthesia. We can use sedation with remifentanil or fentanyl, or we can use local anesthesia aided with oral analgesia. There are some differences between them. Actually, general anesthesia and fentanyl sedation had similar postoperative cardiorespiratory results. But topical anesthesia is found related to more cardiorespiratory instability, and topical anesthesia takes longer time actually, 12 to 16 minutes more to complete the treatment. During the operation, some important points here. Prevention of hypothermia is important. Close monitoring is important for vital signs. Scleral depression can affect the vital signs and can affect the pressure of the eye, and it can cause hypotonia. Actually, we want to rotate the eye instead of powerful depression. In my practice, I prefer to use the worst eye first. As we all know, we use indirect laser delivery systems for ROP, and generally we use transpupillary laser by binocular indirect ophthalmoscopy. And we want to complete laser treatment from the ridge to the oral serrata. But we must be careful about the fovea. We must be careful about the long posterior ciliary arteries at 3 and 9 positions. And we must be careful about the ciliary body near the oral serrata. The power of the lens is so important. We must titrate the power for optimum retinal effect. We want to have just fine burn, not intense white burns. Maybe the threshold point can be 120 millivolt for green laser or 150 millivolt for diode laser. But test burn is so important, and we must adjust the retinal power according to the retinal effect, laser power according to the retinal effect. The duration can be 100 to 200 milliseconds, and interval can be 100 and 300 milliseconds. Near the ridge, we want to have confluent laser spots, maybe a quarter spot size apart. But at the periphery, to be able to decrease the total number of laser counts, we can have we can increase the interval between the spots. Maybe a half or one spot size between the spots is more better. Number of spots is related to width of avascular region, and it's related to power of lens that we use. Actually, we don't count the total numbers. The parameters of the lasers are more important. But we know that the more spots is related to more myopia. So I want to have similar counts for right and left eye to prevent anisometropia. There's an example here. There are again some tips and tricks to improve the likelihood of effective laser. Intensity is important. More laser energy may be required to treat posterior areas than the anterior periphery. So, towards the periphery, we should adjust the laser power and we should decrease it. Long posterior ciliary nerves and long posterior ciliary arteries are important, and we must avoid dense treatment over the 3 and 9 positions. Posterior avascular notch should be treated with laser, but we should pay attention to the fovea, of course. Pupillary dilatation is important. When tunica vasculosa lentis is present and dilatation is limited, gentle messaging to the circumference of the globe provides better view. Scleral depression is important again, but gentle depression is important, not powerful depression. Skip areas are important reason of generally retreatment and recurrences. So we should check the periphery for 12 o'clocks, because the most important skip areas region is between the 11 o'clock and 1 o'clock. Intensity of laser is important again. Dense white burns increases the risk of anterior segment ischemia and increase the risk of cataract or hypotonia. Pupillary dilatation affects the success. Laser treatment with poor dilatation increases the risk of inflammation, increases the risk of focal cataract and anterior chamber hemorrhages risks. Scleral depression is important, as I said before, and sudden release from the depression can cause hemorrhages from the neovascularizations. Before the anti-VEGF area, we used the laser for aggressive ROP cases, you know. For them, we can apply the laser as two-step therapy. First, laser ablation from periphery up to flat neovascularizations. Second, after 5 to 7 days later, after the regression of flat neovascularizations, some gap can be seen and we can laser this area again. But as you know, we prefer to treat these babies with anti-VEGF in recent years. There is an example of aggressive ROP cases who have laser treatment. Success rate is low for the zone 1 cases. So nowadays we can prefer anti-VEGF therapy for zone 1 cases. There are some different applications of laser treatment in the literature. One of them is pattern laser. Pattern laser can be used sometimes in the babies with ROP in flying position. And there is a new literature here published in 2025. They treated one of the eye with the confluent laser and the other eye with limited half number confluent laser. And posterior half eye, they treat only posterior half avascular area, sparing the anterior half, and demonstrated equal anatomical and refractive outcomes compared to conventional pan-avascular photocoagulation in type 1 mid-zone 2 ROP cases. We can use laser as a combination therapy with anti-VEGF and laser. Again, a new literature here from this year. And for the most complex cases, combined regimen with laser and anti-VEGF agent was found more effective than monotherapy, and they said that it prevents late recurrences. They used here two effects: ability of anti-VEGF agents in neutralizing the circulating VEGF molecules, and long-term impact of laser ablation in preventing further release of VEGF by ablating the avascular retina. And using a combination therapy allows for the usage of less dense laser strategy and an appropriate dose of an anti-VEGF agent, which might decrease the adverse events of both modalities. After the laser treatment, we should treat the babies at least 7 days with topical steroids, cycloplegics, antibiotics, or sometimes with topical non-steroidal anti-inflammatory drops. And infants are followed closely for need of additional laser to skip areas, for the inadequate treatment, especially for the 6 and 12 positions. Regression of disease can be seen in 1 or 2 weeks later than the anti-VEGF treatment, and progression risk to retinal detachments can continue up to 6 to 7 weeks. After the 1 week, after initial laser treatment, pupil dilates well, tunica vasculosa lentis regresses, media clarity improves, plus disease reduces, no new vascularizations noted, and capillary non-perfusion zones appear less devoid, especially in aggressive ROP cases, and healing appearance of laser scars begins. After 2 to 3 weeks, ridge flattens and looks less active or less angry, plus disease regresses furtherly, no new traction and vascularizations develops, laser scars distinct and healed in these weeks, and hemorrhage generally clears. 4 weeks later, feeder vessels to elevated ridge achieve normal caliber, and demarcation between the laser-treated and normal retina seems quiet. There are some examples of regression here: regression of plus disease, regression of neovascularizations, and regression of ridge height is so important, and we should them closely check. Retreatment may be needed sometimes. Persistence of plus disease, no regression of stage 3, and the presence of tractions and retinal detachment is important to decide the retreatment. We can add additional laser for skipped areas, and if there is no skipped areas, additional laser to posterior of the ridge can be applied. And we can combine the treatment with anti-VEGF, but for some of the cases we need vitreoretinal surgery. There is an example of case laser application to the posterior side of the ridge may be beneficial to prevent RD in these cases of aggressive fibrosis. There are some preoperative and postoperative risk factors for retinal detachment for the babies who need treatment. Preoperatively, posterior zone 1 disease, periretinal hemorrhages before laser, plus disease more than 2 quadrants, and reach more than 6 clock hours, and the presence of tractions are important risk factors to progress retinal detachment. Postoperatively, after the laser, fibroproliferation, No regression of plus disease, straightness of vascularization, it is important, the sign of risk. The straightness of vessels is so important. Cloudiness of vitreous is an important sign, an important risk factor again. And sometimes vitreous hemorrhages and condensations can cause to go to the retinal detachment. Postoperatively, first control is in the first day and first week for the early complications actually. Anterior segment ischemia, hyphema, iris atrophy, intraocular pressure problems, posterior synechia because of inflammation, intravitreal hemorrhages, exudative retinal detachment, Bruch membrane tears, choroidal detachment and hemorrhages can be seen. But fortunately, the complication rate is very, very low. Anterior segment ischemia is an important problem. We should be careful about the long posterior ciliary arteries at 3 and 9 position again. Anterior segment ischemia can cause corneal opacity, cataract, hypotonia, and phthisis bulbi. If we use excessive power of lens, exudative retinal detachment and choroidal detachment can be a problem for the baby. The most common late complication is myopia, as you all know, but there are some other risks of complications. Band keratopathy, cataract, retinal and vitreal hemorrhages, macular hole, parafoveal scar, macular ectopia, visual field constriction, and night vision problems can be seen. Postoperatively, the first day and first week control is important for early complications and skipped areas and to follow the regression of plus disease. At the second week, we want to have full regression of plus disease, reach disappearance, and spots begins to pigmentation. First month, we want to see the healing of the laser scars and we don't want to see tractions. Long-term follow-up of the all babies are so important for visual acuity and visual quality, contrast, refraction, strabismus, and late retinal complications. Thank you for your attention.
Dr. Tunay, it's a very comprehensive review. So what are your actual indications of laser treatment these days?
If the baby's gestational age, when we plan the treatment, if the baby's gestational age is more than 38 weeks, the transforming growth factor beta is higher in this time, and if we suppress the VEGF with anti-VEGF treatment, we can affect negatively the balance between the VEGF and transforming growth factor beta. So the complication risk and the recurrence risk is very, very high, and the risk of Crunch syndrome is very high in these babies. If the baby has more fibrotic reactions, and if the baby is more than 28 weeks of gestational age, we should think about the laser treatment. And if the baby has peripheric disease, zone 1 anterior disease, for example, the laser treatment can be the first choice, I think. Gestational age, yeah.
So, you know, the way I think about the transition from anti-VEGF, from laser to anti-VEGF, is that they started with the worst results regarding the zone 1 disease, but the laser didn't actually work at all with the EPR studies and the studies done in the United States on the posterior disease, where laser and cryo had really no effect, and the complication rate was really high at the time. So, and anti-VEGF proved to be effective. So, you know, as I'm thinking about if it works for the worst disease, it should work for the less worse disease. But because the Susanna here and the group from Mexico has described the anti-VEGF outside the United States, it wasn't popular in the United States, and people were saying, don't do this, you have liability. And, you know, I've sat with masters in the ROP, and they were totally against the injection, probably because they were not the first ones. This is typical of America. So I use less and less laser in my practice because of the side effects of the laser you mentioned, the whole list of side effects. And I think the anti-VEGF would work, and we really don't know what's exactly going on in the vitreous of the baby. So I would inject and keep an eye on the baby because of the balance of other factors that we don't know about, the insulin growth factor 1 and the TGF. There are some tumor necrosis factor as well involved in. So much is going on, and I wouldn't worry about the systemic complications of injections as long as I'm following up the baby. And actually, I haven't seen these major effects because, to my mind, an injection would last for a few hours, few days, systemically, and it will wane off. So the long-term effects is really a very enigmatic thing to think about. Thank you.
Thank you.
A conjunctivitis, it comes to you for a treatment, and then it has a conjunctivitis. I don't use it. No. I use laser if the baby comes to me with a conjunctivitis. I cannot. But 3 days makes the difference. So I do laser. Sometimes not. But then I check as soon as the baby is
I think what we understand is that we have 2 treatment weapons now against ROP. The anti-VEGF injections, various types, various doses, and we also have laser. And I don't think anybody should think that we can manage ROP without laser. There are instances, one of them she said, even NLD block, there's pus coming from the nose, you don't feel comfortable injecting. So I think as people who are dealing with ROP, we should understand what each of this weapon does, how to handle. So one of them is attacking the VEGF and all chemicals in the eye. It doesn't stop new VEGF from coming. The other one helps to prevent new VEGF from coming, but it doesn't take away the VEGF which is already there, which means the disease can still progress and cause complications. So if we understand the basics of each of these treatments and how it is affecting the retina and which part of the disease we are targeting, we will be in a better position to decide for that particular baby what is the best. What is the best? Yes, the world, including myself, has moved from a lot of laser to more of injections. The disease is also changing. We are seeing much more of aggressive and exudative and bleb-shaped and all sorts of very bad cases coming to us, which requires, everything. It requires laser, it requires injection, it requires surgery in quick tandem. So we will be having, various ways to approach the disease. And I think fora like this, where I thank all the 8 speakers, they've been excellent because they've kept to the time. We are at 11:45 and they've come from countries like Egypt, Portuguese, India, Turkey, and with the decades of experience from diverse areas. And in some areas, some restrictions are there on using Avastin or getting a laser machine in remote areas or getting somebody to screen. So with all that, it's excellent that we can manage to prevent blindness. And I think from the course, the bulk of the work, which is screening, and then the treatment, we've covered in the first session. And thank you for your patience. If there are more questions, please bring it up because we still have 5 minutes more before we break for food and rest. Yeah. So, no, we have 11:45 to 12:15, so we can give up 5 minutes of our break and we can eat some more ROP.
Question about comparison between giving Eylea as compared to anybody has that somebody would like to add, because have numbers who can answer this. Please go ahead.
And then I think comes Eylea, as good or matching Avastin, and then comes Lucentis. My worry is, when we go for the lesser dose ROP, lesser dose injection, this is where you get complications, This is where you have the persistent avascular retina, the reactivation, the new vessel formation, and you have complications. I think half dose is really good, 1/3 of the dose is effective for some
what
time.
dose do you give? 0.4?
0.625 with the bevacizumab. Yeah.
Okay.
Yeah.
Half to 1/3. So this is a consensus. I agree that even Eylea I have started using.
Yeah, Eylea is less bevacizumab, Eylea, and then Lucentis. Lucentis has the worst. Yeah, that's published.
And that's also my experience.
Yes.
So I use almost always
Yeah. I
Avastin.
agree all the time,
I
Susanna.
can use Avastin all the time.
Yes.
So I can choose between all of those. And I try Lucentis. Lucentis recur very much.
Yes.
Not just 30%, but at least at that dose. Then I try Eylea, and I was very similar in the behavior of the aggressive, and then I
Smoother.
love it. Very similar to Avastin. But I don't use
Yeah. Yeah.
So I trust Avastin because I know how we behave.
The problem, Susanna, with Avastin is
Hey, don't push
the
me.
regulatory thing, because, in many countries, they pushed against Avastin for the off-label eye use. So it puts you in liability. So this is the thing, If things go well, ماشي. لو الدنيا مشيتش.
There are always chances of complications.
Of course.
It is not necessarily.
No, not,
The
yeah.
code, the issues are different because there are very critical aspects. And then
That's what you said. So, we are coming from different countries. There are different regulations. There are different perceptions. There are different medical issues. There are even hospital-related issues. There are certain head of department-related issues. It doesn't matter. You have so many things that you can use. And now we are more empowered to use them. So whatever you have in your place. I know there were places in remote parts of India, there was no laser. So they have to be injected. They have to give a second injection. They have to give a third injection. Then they could refer the baby. So, yes. Just have to learn about it. And here we have the here and we are ready.
So I want to ask a question, Dr. Ehab, about the laser. If you have an aggressive posterior ROP and a large avascular zone 2 and 3, do you prefer to just inject and wait, or you would like to do laser to the far periphery of zone 3?
Can I answer that? So I inject and give a chance to Avastin, what inject, to Avastin to make his work. Then he did his work. You are still in zone 1 or posterior zone 2, I inject again. Then he does its work. So that's the way. So you have a weapon, use that weapon, and let her go on. Then you have a third recurrence, and you are in zone 2, and you are not confident that you will not recur again and cannot see the baby because it's far away. You cannot call the parents all the time. Then you can do it. Now, you have a terrible zone 1, and you inject. And even if you inject, you have a progressive RP. So I do laser, I do vitrectomy, I do everything because I know that blood, terrible configuration. So it depends on. But I never do laser. I never do anti-VHF and laser at the same time. Yes, but that's another.
But we published this thing. Should you inject first and then do laser, or do laser and then inject? So we found that the ultimate outcome was same. We did one in one eye, another in other. It's published, and we found that the eyes which had injection first, and then you did laser after 3-4 days because of whatever reasons you decided upfront that I'm going to do combined treatment as she showed. Those babies required less of another intervention as compared to if you do laser first and then after 4-5 days give the injection, because you're doing laser in a hazy meat. So yes, you can decide to do combined treatments, sparing the posterior pole. You can do the injection after 3-4 days. You can do peripheral all laser. This was published from Korea, and then we've also published. and then wait for the posterior pole to develop. So your number of follow-ups decreases and your number of interventions decreases. And this is the strategy you could use where patient says, I can't come, or you can't go to that area again and again. So as I said, we have various combinations now and we can choose.
I'm not very much fan of combined treatments. When I do anti-VEGF injection, I just wait and see if the peripheral retina continues to vascularize, and when it stops, and if I have peripheral persistent avascular retina after some point, like 60 weeks post-menstrual age or more, and then I do an elective scatter laser to those areas. But if I have an aggressive ROP which progressed to stage 4, for example, and if I do vitrectomy for those cases, only the macular area only part of the macula is vascularized in such cases. When I do vitrectomy, I don't do total PRP, total lasering of the avascular retina. I do it like Subhadra does. So I do just peripheral laser and give anti-VEGF at the end of the surgery, just to give, although we have already taken the vitreous, which is full of VEGF, maybe it would, even without anti-VEGF, maybe it will be okay. But since we are not so sure, I give some anti-VEGF at the end of the surgery to help, vascularize. And I have 2 cases, very well documented, waiting for to be written and publicated, but it vascularized. I have some fluorescein angiographies and later. Yeah, of course. We are all like that.
So the question is, why would you do laser and why would you inject in 4A or 4B? Yeah, why? I mean, you have removed the vitreous, you have removed the VEGF, you have removed the vitreous, and you have removed the sliding traction. Why don't you give a chance for the vessels to grow?
Because one, you may not have removed all the vitreous. There's always vitreous there,
there is.
Which has VEGF. Second, when you give the anti-VEGF, it has to work in the retina, not in the vitreous.
Yeah, I understand that you remove the vitreous that induce the traction. So this is the goal.
Yeah, but there is vitreous left behind, and that is VEGF, and the retina is not growing, and you need to give some. But of course, we will get more data. With time, we get more data. And Sengul, we do combined treatment, because when we do combined treatment, the number of follow-ups is 3. When we do monotherapy and follow and then do laser, the number of visits is 10 or 12. So depending on the family patient, if they cannot come 10 times, they can come only 3 or 4 times. Those are the babies where we do one injection. We say, just stay in the city for 3 days more. We'll do the laser in the periphery, and then you can come back after 2 months or something. So the number of visits.
Yeah, we are talking about, aggressive cases, which are posterior disease. We are talking about zone 1 disease mostly, which progressed to stage 4. Then when we are having only very small vascularized retina, and even if it didn't progress to stage 4, if it was just aggressive ROP, if we inject the anti-VEGF, those cases, at least 80%, we have published the data, 80% have persistent avascular retina. That's why we want to do laser to the periphery, because we are expecting that. That's why we are doing the laser to the periphery during the surgery, which prevents, it's a kind of caution.
Some patients come back with
Can I
Even
I
after
tell you about
surgery,
the
laser injection, they come back with very bad detachments.
So-
as if you didn't do anything. They come with massive plus. We don't know why, but they come back.
Subhadra, the experience I have was, as long as you don't remove the whole vitreous, whatever you do, I just remove the posterior. Yeah, the posterior. I had, the patient who were lased 10 and 11 and 12 years later, in like 3 patients, they come with posterior hyaloid contraction and really bad detachment, as you said. So I'm wondering if the laser has a role at all. I don't lase my patients knowing that it would not make a big difference on those, and I keep an eye on them.
Well,